All right, I'm back. Okay, so let's do chapter 42. This is musculoskeletal disorders. So not so much the traumas and the broken bones and stuff, but just people that have musculoskeletal issues. So, the classic one is back pain. Everybody and their brother has back pain, and actually nurses are very high risk for back pain because we're constantly on our feet and we're constantly moving people. So make sure that you're using good body mechanics, that you're using your legs, that you're not bending over and pulling stuff up. Back pain is very common. So you want to teach your patients how to use good mechanics. If they are having back pain, sleeping on a firm mattress is a good idea. Good body mechanics. They can use NSAIDs. If they can rest it for a couple days, that's good. Laying on flat surfaces, so if their back is really hurting, they can lay on the ground. And then depending on what it is, hopefully that'll resolve the issue if it's just a muscle strain. But sometimes it's worse. It could be a disc problem where they have like either degenerative disc disease or a herniated disc. That's very painful. Some of those need more surgical interventions. But you always start minimal. You start with rest, ice compress. You can't really elevate the back, but you would lay flat and on hard surfaces. So that's kind of your back pain. I do want you to know about bursitis and tendonitis. These are conditions that usually occur like in the shoulders or the elbows. Those are also hard to treat because even if you're taking NSAIDs and stuff, it doesn't get to the tendons and ligaments very well because of low blood supply to those areas. So typically you tell your patient to stop doing whatever they were doing, like rowers, on the crew team, they do this a lot where, it's constant stretching here, or tennis players are constantly doing that and they get tennis elbows. Anything with repetitive motion. Another sort of not a complication, but in the same family of disorders is carpal tunnel syndrome. And carpal tunnel syndrome is you've got these nerves and tendons and ligaments that go through your hand, and they all come through kind of like this ring of muscle right about here. Well, if you use this wrist a lot, so for example, like keyboard workers, somebody in a grocery store that's bagging like this all day long, that can become inflamed, and then it can press on those nerves, and this part of the hand can get painful, numbness, tingling. So those are the patients that if you can get them to stop doing that activity, great. A lot of them can't because it's their livelihood, so you put them on NSAIDs, and those are the ones that you can wear a brace to kind of help support that. So it does tell you a little bit about carpal tunnel in there. Ganglion cysts, those are pretty common. Those are like they usually show up like right here on the wrist, and sometimes the elderly people will get them. They're not super painful. Sometimes a little bit painful. It's not a big deal. If it's really painful, you can have it removed. It's like this gel-like substance, and the problem is it starts compressing on those nerves, and it's a little bit sore, but most people just leave it unless you can aspirate it. The foot problems, the biggest one would probably be plantar fasciitis. This is pretty common. The plantar fasciitis is an inflammation of the tendons on the bottom of the foot. It's common in runners and distance runners because the ligament that attaches back in the heel gets overworked and stretched and inflamed, and it's really, really painful. So the treatment there is immobility, to not move it for a while if you can, and stretching. Stretching those ligaments helps a lot. So if they can stop the pounding and then stretch it, then usually they can slowly reintroduce the activity again. So anyway, so that's plantar fasciitis. The rest of these are, you can look over that, but the chances of you seeing something on NCLEX about a corn or a callus or an ingrown toenail or a hammer toe, you kind of need to know what they are. Bunions, foot bunions are big, and that requires surgery, and that's kind of a painful surgery. So you can look through those. I would not spend a lot of time on that stuff. I do want to direct you over to metabolic bone disorders, and there's a couple that I want to focus you on. The first is osteoporosis, because it's really, really common. Osteoporosis is basically just a demineralization of the bones. So as a person ages, the bone, which had been fairly dense, begins to lose its density, and that's a variety of things. Hormones play a lot to do with it, especially postmenopausal women start losing estrogen, and that has a lot to do with bone density. So as people age, especially in women, it's more common in women, they can start developing osteoporosis, and a classic sign is they start shrinking. And there's a good example of this on figure 42.9. As a person ages, they'll start shrinking because the bone, and you can look at figure 42.8, where you can see that bone. See how it's so, it looks wispy and airy, almost almost like cotton candy. Your bones should not look like that. They should look really dense. But those bones, there's a lot of bone loss occurring there. So, and there's a lot of different things that can cause osteoporosis. Some of them are non-modifiable. You can't modify your gender, you can't modify your age. But there's other things, like you can do weight-bearing exercises, you can eat high calcium, high vitamin D in your diet. This figure 42.7, the risk factors for osteoporosis, is excellent. So I would highly recommend that you know that, because there's some things like caffeine, alcohol, smoking, things like that. If your patient does those, if you eliminate them, it will improve their risk for developing osteoporosis. So that's important to know. It's also important to know, like primary osteoporosis, it just occurs because of age and hormones. It's just you know, a result of things that you can't control. There's also secondary osteoporosis, and that's a result of like medications or diseases that affect the bones. So primary is just you've got osteoporosis, and secondary is you have some cancer, or you've been on long-term steroids or something like that, and now you have bone loss. So that's primary versus secondary osteoporosis. So do spend some time making sure that you know a little bit about osteoporosis. And this is what I was telling you about the calcitonin. I think we talked about that in one of our previous lectures. Calcitonin inhibits bone reabsorption and promotes bone formation. That is decreased in patients who have osteoporosis. So, and people can take calcitonin, which is actually a good drug in patients that have osteoporosis. I'm having earring issues. Okay, so I do want you to know that. So make sure that you're understanding osteoporosis. The other thing with osteoporosis is because those bones are so thin, you need to be really, really careful to teach your patients how to avoid falls. And because usually osteoporosis occurs in the elderly and they are at higher risk for falls. Well, if they fall, if your osteoporosis patients fall, those bones are much more likely to fracture, and now we have a bigger problem. And falls in the elderly are a high cause of death, because especially if they fracture a hip, they go to the hospital and they can get pneumonia, and it's very significant if your elderly patient gets with osteoporosis, falls and breaks something. So your patients who are elderly and known to have osteoporosis, even if they don't have osteoporosis, you want to prevent falls, but especially in people that have osteoporosis. So you want to do things like good lighting in their house. Get up all the scatter rugs. They should not have any scatter rugs because that's a trip, fall risk. Good shoes, good leather-soled shoes, not open-toed, not heels or anything like that. I'm going to be a horrible old person because I like my heels. Good calcium, good vitamin D, things like that. Rails like in the shower and on the toilets and stuff to help them up and down so they're not falling, because you really want to avoid fractures in the elderly. Somebody who has osteoporosis. So read through page 1144, medical and pharmacological management for somebody who has osteoporosis. Okay, the next thing I just wanted to point out is Paget's disease. Paget's disease isn't, it's not super common, but it is one of the bone disorders that you probably need to know about. Paget's disease, there is a genetic component to it. They think it tends to run in families. And it affects the skull, where the skull tends to be huge, bigger than, and like an overgrowth of the skull. Sometimes it's the whole head, sometimes it's just the skull, so the face is little and the skull is larger. And you diagnose it on x-ray, and oftentimes people who are being worked out for something else, they'll figure it out when they're getting x-rays. It can, because it involves the skull, it can impinge on some of the nerves. So your patients with Paget's disease sometimes can have hearing loss. It's painful. It's a painful disease, so you need to treat them for pain. They often have impaired physical mobility because it is a disease that affects the bones. They can have altered self-image because their head is so big. One thing that is common in somebody with Paget's disease is they will have normal blood calcium levels, which you would think their calcium levels would be high because of the high turnover of bone, but they've got normal calcium levels, and they have elevated serum ALPs. Now your ALP, alkaline phosphate, we talk about that mostly in our liver patients, but it has a lot to do with bone disorders as well. Your normal ALP is between 44 and 147. So in a patient with Paget's disease, that ALP will be elevated. It'll be greater than 147, but the calcium levels, which you'll recall your normal calcium is 8 to 10, your calcium levels will be normal. So those are some of the things that are indicative that your patient got Paget's disease. And there are some medications. They do have some medications now. Mithrasin and some of the biphosphonates are useful in treating your patients with Paget's disease, so kind of read up on pharmacological therapies on that. Then I did want to talk about osteomyelitis. We talked about it a little bit in the last chapter, chapter 41, but osteomyelitis is an infection of the bone, very difficult infection to treat, and often follows open fractures, surgical what am I trying to say, interventions in the bone. So, what else do I want you to know? So in acute osteomyelitis, this is often following, like an open fracture or the bone that's been exposed to the air. Now, when you are suspecting that your patient is now developing osteomyelitis, there's a couple diagnostic things. So where it says findings, I want you to kind of be familiar with the findings. Somebody with osteomyelitis will have elevated white blood cells, specifically the leukocytes. And if you'll recall, normal white bloods are between 4 to 10,000. So anything greater than 10,000 is they're going to have high white blood cells. You're going to expect that your patient that has osteomyelitis, they will have fever, general malaise, and another classic indicator is the ESR, the erythrocyte sedimentation rate. Your ESR should be between 15 and 30, and that's just a measure of how quickly the erythrocytes settle in a test tube, and it's an indication of inflammation. And in your patient who has acute osteomyelitis, their white blood cells will be up, and their ESR will be elevated. So those are two, and in given a good history, and then if they start developing fever, that's pretty good indication that they're starting to develop osteomyelitis. And then they need to be on usually IV antibiotics, and if that starts helping, then they can be on oral antibiotics, but sometimes it's up to 6 months. And if it develops into chronic osteomyelitis, then it's even longer than that. Once it develops into chronic osteomyelitis, then the white blood cells come down and the ESR comes within normal limits. The alk phos, did I talk about your alk phos? I can't remember if I talked about alk phos or not. No, yeah, I think I talked about normal alk phos. Yeah. If not, remind me, I'll tell you about it in class. Okay, so then the medical management and the pharmacological management of osteomyelitis, I already told you about that, mostly antibiotics, but sometimes they have to go in surgically because it's so hard to get the antibiotic to the bone. Okay, bone tumors, I want to run over this really quick. Primary bone tumors, like cancer that starts in the bone, is super rare. It's not very common at all. You can get tumors in the bones that are not malignant, and they have to be removed, just like in some of your patients we talked about during Neuro Week, where you have a meningioma or something like an OMA, that it is an overgrowth. It's usually well encapsulated, well differentiated, but it still has to come out because there's nowhere for it to go. Those are like primary bone tumors. The more difficult thing to deal with as a nurse is the metastatic bone cancers. Lots of cancers love to metastasize to the bone. The problem is, once the cancer's metastasized to the bone, there's really not a whole lot that you can do about it. Chemotherapy and radiation is not going to help because it's coming from another source, so that's the cancer's obviously spreading. So usually when the patient has metastatic bone cancer, we just use palliative measures. Lots of pain medications. You might want to get hospice involved. Occasionally they'll go in and debulk it. Like if it's in the spine or something that's causing the person to not be able to walk, they might debulk it, but it's never curative. It's just palliative, and it's kind of an ominous sign. Most people don't recover once it's mets to the bone. We just take care of them and make them comfortable. Let's see if there's anything else I want you guys to know. Yeah, that's all you need to know for chapter 42. And then in chapter 43, we're going to go into more like specifics on bone trauma. But that's really the bone and joint disorders that I need you to know about. So, okay, and we'll come back next time and do chapter 43. Okay, see ya.